Wow, all I can say is this has been a tremendous year.
It really has.
Patty has been with us for an entire year, and we have been so incredibly productive in our research experiences. How many papers have we published?
Okay, so total we have 5 papers published, and that's not including papers that are currently submitted. So they will be published in the next few months, but for right now we got 5 publications, including 3 prospective randomized control trials that are approved by IRB. I think it's been a phenomenally successful year.
Very, very productive. And so Patty and I met almost 3 years ago when she was an extern in the program that the Aesthetic Society had set up for plastic surgery-minded medical students who were not exposed to plastic surgery programs in their own medical school. So in your medical school, you had no plastic surgery program, correct?
Correct. No, we do not have a home residency program, and so I was eligible to apply for the externship program sponsored by the Aesthetic Society, which offered me the opportunity to link up with a mentor, and in that case, it was Dr. Claytor, and so this was almost 3 years ago.
Yeah. So back then, you came and spent a week, and we went to the operating room together, and you really got to experience what it would be like to be a rotating medical student in a plastic surgery division. And that experience for you was super positive, and we had a great relationship. And the competitiveness of plastic surgery residencies is such that many high-level students are looking to become even more competitive. And one of the ways that medical students are doing it today is they are taking a research year. And I am very fond of this program since I did 2 years in research while I was a general surgery resident. I went out between my second and third year and went into the lab and actually did 2 years of basic science research in platelet physiology. At the time, I was thinking that was a lot. But as I look back on it, it allowed me to gain the tools that allowed me to today be able to be a clinician researcher. So I'm full-time, very, very busy clinical plastic surgeon, but I have a tremendous passion for understanding and unlocking the secrets of plastic surgery. And so Patty has come and spent a year with me, and it's been very, very productive as we have published 5 papers. So let's start looking at them. Let's first start looking at recombinant platelet-derived growth factor versus autologous nanofat to enhance recovery after CO2 laser microneedling, a split-face randomized control trial. That is a mouthful. This is published in ASJ Open Forum, and I mean, I feel like we've really jumped right to the top, and all the other papers are going to have a hard time leveling up with this one. But this is level 2 evidence. Tell everybody what level 2 evidence means.
Every paper that's published is giving a level of evidence depending on the type of study. So this particular study had a smaller group sample. However, it was a very, very strong randomized controlled trial, and so it was given a level 2.
Yes, and so what randomized control means, the patient, once they entered into the study, they allowed us to pick which side would get the standard treatment, which was CO2 lasering, microneedling, and nanofat. And then the other side was CO2 laser, microneedling, and PDGF. And the patients were blinded to it, so they didn't know which side they had. And obviously, I had to know because I was doing the treatment. But then they were grading their results as we went along. And on top of that, we took tissue biopsies, which was the first time that tissue biopsies, face tissue biopsies, had been used with PDGF. So this was incredibly groundbreaking and impressive data that showed really a very impressive similarity of the results, the short and long-term results, because we went out to 6 months doing tissue biopsies on these patients, showed that the results early on were a faster recovery for nanofat, but with PDGF it caught up quickly, and by 6 months they were identical. What was the other thing that was fascinating about the pain?
So for both, and let me backtrack a little bit, prior microneedling and CO2 laser, they were not used in combination because they would cause significant pain, particularly due to the thermal heat that would be applied to the skin, essentially causing a second degree,
Well, it's a
third degree.
It's a partial skin burn. That's what CO2 lasering is.
And so it would cause significant pain for patients. But we saw that even immediately after application of both autologous nanofat and recombinant PDGF, there was significant reduction in pain scores. at the time of application of the treatment and after the application of the treatment.
Yeah.
Very important findings.
And tremendously accelerated recovery. And so the theory is that nanofat is chopped up tissue with tiny little lipid bubbles, lipid droplets that pass through these microneedling holes, and they go down and deliver their extracellular matrix proteins, the cytokines, stem cells, all of these amazing rejuvenation material to the tissue. Turns out PDGF does this very similarly, which is fantastic, because now you don't have to make an incision and suction fat. You just pull it off the shelf and it's ready to go. And of course, that's very attractive to patients.
Exactly. So another option for patients, and you can read this in the ASJ Open.
Yeah. All right, next paper is, why don't you read it?
All right, so our next paper is Redefining Neck Rejuvenation, the Novel Hyoid to Mastoid Crevasse, Neoligament, and Undercake Angle in Deep Plane Neck Lift. So this was another exciting paper that we were able to put together, and it was based on Dr. Claytor's technique called the Hyoid to Mastoid Crevasse, which essentially is to take on Giampapa. I didn't want to say it.
Sure, no. Yeah, it's basically the concept of, and it's even more and more exciting today because there are more and more challenges and questions as to whether or not we should or could, or is removing the submandibular gland something that should be done. I firmly believe that it is, and there are many other surgeons out there who agree with me, but just what makes a great spirited debate is there are certainly some who are challenging this and saying maybe you shouldn't. But then the question comes up, how do you deal with the patient that has a very large submandibular gland? Because it really can dramatically obstruct that beautiful angle of the jaw. And so the concept was that if you put a suture between the hyoid bone and then back into the mastoid bone, it acts as this basically very, very strong, we call it a neoligament. It's so powerful in controlling the gland. And we haven't put it in this paper, it's going to be in the next paper, but we went down to Miami and in the cadaver lab did CAT scans on cadaver heads, and we then elevated the hyoid bone using the suture and then rescanned them to see the difference. And we saw a statistically significant change in movement of the position of the hyoid relative to the mastoid bone, which really correlates well with creating that beautiful cervical mental angle. But further in this paper,
as an adjunct, we wanted to name a new angle, and this angle can be seen from the posterior oblique view. And so the name is ondercake, which in Dutch translates to under the mandible, under the jaw. And we really wanted to captivate a new angle that can look at the area below the submandibular gland.
Yeah, perfectly said. And so everybody knows about the cervical mental angle and the guineal angle, but nobody had ever really described this area. And what really lit it up and made me realize that this is an area that nobody is talking about is because nobody ever looks at that posterior oblique view when you're looking away back this way. And it's because all the views are, 3/4 inside view. Nobody was shooting a view from behind. So I had gotten that OVO camera, which is this 360-degree camera, and all of a sudden my eyes were open to this posterior oblique view. And when I was addressing the gland, you saw this beautiful, almost like the bow of a ship, this beautiful curved shape up underneath the jawline. I realized nobody had ever named this before. So thus came the undercake angle. And so now it's in the literature and hopefully it sticks. All right, what's next?
So moving on to the next one. So this was a big retrospective review, and it's called Drainless Lipoabdominoplasty Using Progressive Tension Sutures, Scarpa's Fascia Preservation, and Minimal Cautery in 350 consecutive cases. So this was also another exciting look at drainless lipoabdominoplasty, which some have named it a paradigm shift.
But really, I was inspired to start doing abdominoplasties without drains when I had a patient who wrapped her drain around a doorknob and she pulled it out. But I was like, something's got to be done differently. And as it turns out, the Brazilians had really pioneered this, and I merely adopted the techniques that they had pioneered. And there are multiple little maneuvers, and it's all in the paper, so you can read it and start doing it if you so choose. But this is definitely a growing concept, and I will see patients come in and they're like, well, I really want to find a surgeon who does this without drains. I'm like, okay, been doing it for almost 20 years, and we've published papers on it. So it's great to have this in print so that other surgeons can learn from it. And also it's a great resource for patients as they are looking for validation that this is something that's achievable.
And it's evidence that without drains and using proper technique, we can reduce or maintain a low complication profile, particularly with seroma complications, which is what we're worried about, and by putting in a drain in the first place.
Absolutely. All right. Okay. That's another paper. What else?
We have one that is in progress right now, and it's the novel minimally invasive mastoid sling for a non-surgical neck lift, a combination of liposuction, thermal energy, and suture suspension for neck rejuvenation. So this is another techniques paper inspired by one of Dr. Claytor's techniques for neck lift called the MIMS, or the minimally invasive mastoid sling. And this is a great option for patients with mild to moderate skin laxity in the neck that maybe don't need an open dissection neck lift. And so this proves that this can be done for particular patient population, especially nowadays when some patients are seeking minor touch-ups, something that's minimally invasive that isn't going to require, long visits or a long recovery time. And so this is a great paper to show another innovation in neck rejuvenation and particularly minimally invasive options.
Beautifully said. I just want to give a little shout out to Greg Miller, who really pioneered the My Elevate technique that this was inspired from. And I just took his whole technique and just added a few little twists. And the twists were that instead of completely non-surgical with percutaneous suturing, I make a small incision back behind the ear. And the reason it's called the MIMS, is minimally invasive mastoid sling, is I make a little incision directly over the mastoid bone and go create a sling around the mastoid fascia. And that's what is a very, very powerful anchor, so that when I tie the suture here, it can really tighten and contour the neckline. And I do that with a permanent suture. And then we follow that up with an absorbable suture. And that second suture is very superficial, right in the skin. And it dissolves in about 3 weeks. But I tie that one very, very tight, and it creates a lot of puckering. And of course, if that stayed, it would be unacceptable. But in the short term, it's perfectly fine. And it really helps tighten up and contour that neck. And then there are a few little additions of microneedling on top of that to smooth it out. And then we also use Andre Arswell's hemostatic net to also help that tissue adhere down. And so these results are really incredible. And I've had very, very well-known international surgeons who do nothing but facelifts make comments on, oh my God, what are you doing? That is truly amazing. And so I get patients coming from all over the place for this kind of technique, and I'm so proud that this is going to now be in the literature for people to be able to resource and learn from, not only surgeons to learn, but also patients, because a lot of patients find these papers and they read them and they come in and say, this is very interesting. I would like to have that particular technique. So it's nice to have this in the literature. Exactly. All right, that's 4. What's next?
And then our last one was one of our first papers that was published, and this is Awake Rejuvenation with the Deep Plane Facelift and Extended Deep Neck Contouring. So this was also one of the first topics that I ever presented in a podium. That was at the Aesthetic Society in Vancouver, I want to say.
Very good.
And so it was great to follow that project through and see it to publication. And essentially this is a look at the deep plane facelift, but with local anesthesia and how it can be done with the patient awake, which is, again, a paradigm shift, because oftentimes this procedure is done under general anesthesia, and really seeing it in person and then being able to write it in a manuscript is incredible, and gives providers and patients other options that maybe, particularly for patients that may not be able to go under general anesthesia.
That's true, but there are even patients who are perfectly reasonable candidates for general anesthesia who actually seek this out, and they say, I want to not have general anesthesia. I'm very specific that this is not, office. This is in an operating room. Now, it happens to be located just adjacent to my office, but this is not like you're doing it in the examining room where you normally would see patients. This is a full-blown, nationally accredited operating room, but the patients are awake while you're doing the procedure. And this even includes removing submandibular glands and deep plane technique. And this is a review of the last 200 patients that I had done this way. And it really is, again, as you said, a paradigm shift and a bit of a disruptor in the entire algorithm. And it's so cutting edge that there are individuals in the social media world who are like, I'm just not really ready to start talking about it. It might be a little too cutting edge. And that's my entire vibe. My entire vibe is being cutting edge. And I guess when I was recently down in Brazil giving a talk about a lot of this, the Brazilians came up to me and they said, we have a nickname for you. And they said, we have named you the Great Disruptor. And so this is very disruptive because I've had individuals, even one of the reviewers for the paper wrote back and said, well, what happens if you have an issue while you're operating and you don't have an anesthesiologist? And okay, well, how is that anesthesiologist going to help you in that particular situation? So it's about prior planning and being prepared so that you can anticipate the issues that are going to come up. It's about important patient selection. It's about the patients feeling comfortable. It's about the surgeon being comfortable. Honestly, many people who come and watch me do this, and at the end of it, they just go, I don't think that I, meaning them, would feel comfortable doing this operation on a patient awake, mostly because they're just probably not that comfortable with the technique yet. And so it definitely requires a tremendous amount of confidence and comfort from the surgeon, as well as my entire team, which is highly skilled, and having the right facilities. I do not advocate doing this, in your office. I advocate doing this in an operating room, but it just happens to be under local anesthesia. And as I've shown, it's published, it's in the literature, it's safe, it can be done, and the results can be exceptional.
And then one of the most unsung parts of doing a research here is obtaining IRB approval. And so that's Institutional Review Board.
Yeah.
And so this is a very important part of carrying out any research project.
It's mandatory.
And it takes months, lots of paperwork and meetings in order to get approval. And I'm very happy to say that we have approval for 3 prospective randomized control trials, which is not a small task.
It's huge.
And so one of the big ones is our study on remote ischemic preconditioning to analyze adipocyte viability after fat grafting. And so this is a research project that we've been able to collaborate with the University of Pennsylvania and be able to carry out basic science, bench science research, and really analyze what is happening to adipocytes after they've come out of the body in lipoaspirate, and how are their genes changing? Like, what is happening with these cells?
Yeah, this is a difficult topic to really understand if you're a layperson, and so let me go back a little bit because you did a great job explaining it. The challenge that we have today is when you harvest fat from one part of the body and move it to another part of the body. So if you take it from your abdomen and you put it in your face or your breast or the buttock region, what we're generally finding across all plastic surgeons is that we get about 50% viability. About half of it takes. Sometimes it's even less than that. And in the last 30 years, there have been no really big innovations. I will give a shout out to Tiger. They have P188, which is a membrane stabilizer that they use in their fat grafting system. And so it's shown some very impressive improvements. And it really gets to understanding that when you pull this fat out, it's traumatized. And this helps stabilize the cell membrane. But I wanted to go back even further and look at, can we modulate the milieu, the patient themselves before we pull that fat out? And so this was a study where we looked at utilizing fat that we are pulling out of the body. But first, what we're doing is we are remote ischemic preconditioning to one part of the body. And so their leg would be made ischemic. But first, you'd pull some fat out of their flank, and we sent it down to Penn with our whole team driving back and forth each time. So it was very rapidly evaluated. And then we made their extremity ischemic. And then we went and took fat from the other part of the body. And so we were able to tell in real time, are there gene expression changes between the fat that was harvested as a control versus the fat that was removed after it had seen remote ischemia, so not
Right.
direct ischemia, but the leg was made ischemic, and then once we let the leg tourniquet, it's just a tourniquet that you would use for any kind of orthopedic procedure, so it was nothing novel in that, but it was the application of it. And then, so with this fat, see some changes, and we saw some incredible differences showing change in inflammation, change in adipogenesis, and also that these cells that saw this preconditioning went into cell cycle arrest. And what that means is that these cells basically went into a condition where they can much more readily be brought back to life, if you will, as opposed to going down a programmed cell death pathway. So we'll continue to evaluate this, but this preliminary data is out of control and so incredible in its ability to theoretically, with the results that we're seeing, these cells are exhibiting markers that would indicate that they are going to have a higher percentage of survival once they're transplanted back into the patient. So this could be one of the most transformative changes that are brought to cell transfer and cell transplant in a generation. Patty's been a big part of it.
Okay. And then 2 other approved studies is one for observing autologous nanofat after grafting it into a wound and to see what wound healing would look like. And so this would be a split face after a patient has undergone a facelift and with application of the nanofat onto the wound and then observing it over the course of 6 months. Is the healing better? Has their scars improved? And is swelling gone down faster compared to doing nothing or doing autologous nanofat? So very exciting.
It is exciting. And so they're actually, these are 2 very similar. They're separate. One of them is injecting the nanofat into the scar. So that would be, we do a facelift and half the face would get nanofat injected into the scar. And really the data is out there to suggest that this is going to tremendously improve the quality of the scars. And so we're in the middle of doing that one. This other one, really, I'm so excited about this one because I was talking to Patrick Tunard and Alex Verpeel, who are the 2 individuals who invented nanofat. And I was sharing with them all of the amazing things that I was finding when I was laying nanofat on the face after CO2 lasering and microneedling, and that we saw a tremendous acceleration in the wound healing, and even more importantly, the pain went to almost 0, which is just mind-blowing because one of the big challenges we have with CO2 lasering is that it really hurts. And here we saw the pain went to 0. So I'm like, something is going on at the level of the nerves. And so one of the challenges that we have after facelift surgery is that it can be painful and very swollen. And so this is going to be such an exciting paper where half of the face, we're going to be laying the nanofat on top in the wound as we close, and the other side we won't do anything. And so the patient will be randomized. They won't know which side we did which to, and so they'll be able to tell us does one side hurt more than the other. So I think we're going to be able to tell very quickly if this is something that is actually improving pain relief, and then the swelling is going to be a little bit harder to follow along, but we have different metrics that we're going to be able to use for that. So these are some really exciting papers that we have coming up doing research on. And there's another research fellow who's coming next year, Daniel Lehman, who's going to take over from Patty. And so we've got great continuity in the program so that we've got great achievements and great potential in the future. And so this is a very sad time for me because Patty is going to be moving on, but it's also a very happy time for me because I know that she has done such incredible work that this will vault her into an amazing residency that she's going to be able to start almost a year and a half from now.
That's
a year and a couple of months from now.
Exactly.
So thank you again so much. It's been my honor and pleasure to be able to work with you for the last year, and I'm very grateful.
Me too. Thank you.